Hello, my name is Sierra Jones, and this is my Occupational Therapy Doctoral Capstone, a feasibility study of the Community Clubhouse Self-Advocacy Program. First and foremost, I would like to thank Midwest Brain Injury Clubhouse and the members for allowing me to bring my program to them. I'd like to thank Billy Tatum, my state mentor, for helping me guide the program, and I'd like to especially thank Dr. Laura Van Pumbrick, who allowed me to take a program she and her advisor had previously completed and make it my own within my capstone. This doctoral capstone experience and project took place at Midwest Brain Injury Clubhouse, which is a community-based setting in Chicago, Illinois, that offers rehabilitative support for those with physical and cognitive disabilities due to acquired brain injuries. Midwest Brain Injury Clubhouse is run using the Clubhouse model. This means that participants are referred to as members to ensure feelings of inclusivity at the clubhouse. The members are expected to contribute to the daily functioning and management of the clubhouse as part of the rehabilitation process. Doing so adds meaning and purpose to the lives of members, as well as increases their capability to participate in IDLs and ADLs. The goal of the clubhouse is to facilitate maintenance and improvement in members' skills, decrease socialization, and improve quality of life. The problem statement for this project is: those with disabilities often face healthcare disparities when it comes to the level of care from care providers, health status, and healthcare costs. The barriers this population experiences lead to a lower quality of life. In 2006, it was reported that 1 in 4 adults in the US have a disability. These disabilities include hearing, vision, cognition, mobility, self-care, and independent living. Reichard, Stolz, and Fox conducted an analysis comparing the rates of disease, preventative care, and healthcare expenditures among those with disabilities to those without a disability in the US. It was found that those with the disabilities more commonly reported a low health status than did those without a disability. Similarly, they also exhibit a higher prevalence of multiple chronic diseases. Through their research, the researchers found that those with disabilities were less likely to receive preventative screenings, suggesting a lack of public programs addressing this population. The Community Clubhouse Self-Advocacy Program was designed to help members increase their knowledge of the healthcare system and increase their self-advocacy skills to be utilized within the healthcare system. The goal of running a program like this is to decrease the barriers experienced by this population through teaching self-advocacy skills. As described in an article by Tickle Degning, occupational therapy interventions often include the blending of several active agents, generally involving person, environment, and occupation. Due to this, outcomes tend to be theoretical-based, such as quality of life and occupational performance. This creates interventions that are not highly standardized, making research a difficult task. As a result, running pilot studies or randomized control trials first does not often lead to statistically significant results, rendering further studies irrelevant. Feasibility studies are an important part of research because they help build the foundation for the gold standard RCT. Feasibility studies do so by studying the different aspects of a planned trial and determining the feasibility of each piece to ensure validity of the trial as a whole. The purpose of conducting a feasibility study on the Community Clubhouse Self-Advocacy Program is to determine whether the program is feasible and acceptable, so that modifications can be made to create a program that will yield the results wanted and can thus be piloted within similar communities. Race and ethnicity differences are recognized as being inequities that lead to health and healthcare disparities. However, disability is not yet recognized as a difference. Until recently, the disability population has gone unrecognized as being a group that suffers greatly from health disparities. This lack in recognition leads to the health and healthcare-related disparities. Those with disabilities are 4 times more likely than those without disabilities to report a fair or poor health status. Those who lack access to healthcare often experience what is called a cascade of disparities. This is when an individual experiences many different health conditions that stem from both their original condition and the lack of healthcare access they have to combat it. Mead, Mahudi, and Lee state that those with disabilities face 3 common disparities: preventable chronic conditions, early mortality, and oral diseases. It's noted in this article that the most modifiable factor to reduce these disparities is by modifying access to healthcare. In a systematic review by Cron, Hammond, and Turner, it was found that some barriers to accessing healthcare were lack of transportation, the illness being assessed as not serious, and the inability to find a physician. The lack of healthcare for individuals with disabilities I've outlined suggests a need for more structured programming within community settings to facilitate knowledge of and self-advocacy within the healthcare system. The model used to ground this capstone project is the Person, Environment, Occupation, Performance model. The premise of this model is that the interaction between person, environment, and occupation creates or breaks one's performance. In this capstone project, the aim was to determine the feasibility of running a program focused on increasing self-advocacy. In order to curate a program that meets the specific needs of the unique population, the interaction between person, environment, and occupation was imperative in understanding the acceptability of the program process and materials by members. By delving into the specific characteristics of the individuals participating in the program, I was better able to tailor the program to their specific needs, whether that be how the material was presented or what types of material was presented to them. In the setting of MBIC, the program material mainly focused on how to educate those who have suffered an acquired brain injury on self-advocacy. I aim to impact the members' daily occupations as well as the occupation of being a self-advocate by educating them about the importance of being a self-advocate and what it can do for their everyday routines, not just when directly in contact with the healthcare system. While completing the doctoral capstone experience, I provided assistance to the staff at Midwest Brain Injury Clubhouse by assisting members with the daily routines and leading group programs when needed. In response to the precautions and outcomes regarding COVID-19, I participated in online conferences to educate myself and created resources for members to be utilized during times like these. While completing my project at MBIC, these are the objectives I completed. 1. Student will master the pre-existing program protocol. I did this by meeting with a faculty mentor to review the manuscript of the program before I started, educating the peer leader on the details of the modified program, and developed the existing program protocol. 2. Student will implement a program with members at MBIC to increase self-advocacy within the healthcare system. I did this by modifying the modules from the original study and implementing a schedule to accommodate the learned needs of members at MBIC. I constructed a schedule detailing the program curriculum, met with the faculty and site advisors for approval. I taught programs to members to increase knowledge and strategies for self-advocacy within the healthcare system. And 3, student will evaluate the feasibility of the intervention plan within a community setting. I did this by facilitating discussions with the group members to identify program efficacy and efficiency, and I evaluated the adapted program materials to confirm fit with identified needs of Midwest Brain Injury Clubhouse members. Is a program to increase self-advocacy within the healthcare system feasible and acceptable by the participants to be run in a community clubhouse setting in a population with both physical and cognitive deficits? This question aimed to address the issues of health disparities that are faced by those with disabilities by conducting a program that could prove to be a viable intervention to undertake any number of those health disparities. The project design was descriptive and non-experimental. It was granted approval by the affiliated University Institutional Review Board. Participants were recruited through the program coordinator at MBIC. The program coordinator utilized his knowledge about the members to recruit participants that would meet the inclusion and exclusion criteria. The inclusion criteria included 1, must be a member of Midwest Brain Injury Clubhouse, 2, must be 18 years of age or older, and 3, must speak English. Exclusion criteria included any individual unable to participate in a group dynamic for 30 to 60 minutes based on their own self-assessment. 14 members between the ages of 25 and 70 were identified as appropriate for participation in the program. After dissemination of the IRB consent form, 3 members returned their consent forms to participate in the program. 2 of those participants were male and 1 was female. Throughout the duration of the program, no identifying information was collected from any of the program participants. They were assigned a number example, participant 1, that was utilized on in all assessments and within the session transcriptions. Participants completed the Patient Activation Measure 13 and the Rapid Estimate of Adult Literacy in Medicine revised at baseline. The Patient Activation Measure is a 13-item self-reported measure that utilizes a Likert scale. It is an assessment used to determine an individual's skill, knowledge, and confidence in managing their health. The Rapid Estimate of Adult Literacy in Medicine revised is an assessment used to determine whether an individual is at risk for poor health literacy. The assessment consists of 11 words: fat, flu, pill, osteoporosis, allergic, jaundice, anemia, fatigue, directed, colitis, and constipation. All data collection was completed by an IRB certified researcher. Due to the nature of feasibility studies, outcomes are often measured utilizing qualitative analysis, descriptive statistics, and a compilation of basic data. Since the focus of the project was to study the feasibility of implementing the Community Clubhouse Self-Advocacy Program, non-quantifiable information was gathered regarding how well the program was run and the appropriateness of the materials utilized within the program, utilizing qualitative analysis, descriptive statistics, and a compilation of basic data. Participants of the program were administered the PAM-13 and RELM-R before beginning the Community Clubhouse Self-Advocacy Program. These are some of the responses from participants on the PAM-13. Some of these questions are: I am the person who is responsible for taking care of my health. Taking an active role in my own health care is the most important thing that affects my health. I am confident I can help prevent or reduce problems associated with my health. I understand my health problems and what causes them, and know how to prevent problems with my health. The Likert scale ranged from agree strongly, agree, disagree, disagree strongly, and not available. The RELM-R consists of 11 words. The words fat, flu, and pill are not counted in the final score and are placed in the assessment to increase confidence and decrease test anxiety. Words marked correct are tallied up to create the score. A score of 6 or less suggests the individual is at risk for poor health literacy. Participant 1 scored 0, demonstrating the inability to pronounce any of the counted words correctly. Participant 2 and 3 both scored 8, demonstrating the ability to pronounce all words correctly. For the purpose of the feasibility study, these assessments were used to understand the baseline knowledge and skills of the members in order to inform the modifications to the modules to meet their unique needs and abilities. Due to precautions regarding COVID-19, these assessments were not administered at the end of the program as originally intended. The program and lessons taught during the Community Clubhouse Self-Advocacy Program were intended to be translated from a study by Magassi and Van Prembroek. The topics of the 4 lessons of the program that were implemented are as follows: negotiating the healthcare system as a person with a disability, the basics, acquired brain injuries, why self-advocacy, and self-advocacy how-to. The first lesson focused on asking questions to the members to understand their involvement in and understanding of their healthcare. Questions asked include: how often do you visit the doctor's office? What is done at your annual checkups? Who talks to your doctor, you or your guardian? Who makes doctor's appointments? What do you want to know more about in regards to your healthcare? Following this lesson, it was requested by participants to learn more about their injuries and how it affects their health. The second lesson focused on educating the members about acquired brain injuries, how the symptoms of their injuries may manifest, and how learning about their injury can help them be a better self-advocate. Lessons 3 and 4 focused on educating the participants on what self-advocacy is, the benefits of being a self-advocate, the skills needed to be a self-advocate, and how to practice those skills. Within these lessons, I narrowed the focus of healthcare to the specific site of the Clubhouse in order to make the content more relevant to the members' immediate needs and healthcare experiences. In conjunction with lessons 3 and 4, with the help of me, participants made action plans to identify the goals they have related to their health within the Clubhouse and the steps they could take to reach those goals utilizing self-advocacy skills. During this activity, participants required maximal coaching and cueing to come up with goals and objectives to utilize to achieve them. Whether the Community Clubhouse Self-Advocacy program was acceptable was determined by the participants based on their feedback throughout the session on the materials and products being presented to them. Throughout the program, participants engaged with the researcher by asking questions and suggesting topics to cover in the next lesson. Feedback on the acceptability of the program as a whole from the participants was not collected due to the program abruptly ending due to COVID-19 precautions. Whether the program was feasible was determined by the researcher based on the experiences of attempting to run the sessions and on the information gathered while running the sessions. Throughout the sessions, members were encouraged to provide feedback to the researcher. Each session, the researcher asked the members what topics or information they felt would be beneficial for them to be taught to ensure that the lessons were client-centered. Following the abrupt conclusion of the program, it was determined by the researcher that the program run at MBIC was not feasible and would require maximum modifications to be feasible within this site. It was determined early on that the products from the Megassi study were not going to feasibly be translated for the Clubhouse population. To begin with, this was due to the addition of cognitive disabilities experienced by those in the Clubhouse population that was not present in the population of the original study done by Megassi and Van Pumbrick. The major focus of the Megassi study was to empower participants to self-advocate within the healthcare system of the doctor's office and other settings of the like. With the majority of members at MBIC not being their own legal guardians, many of the activities involved in the Megassi study were not relevant or appropriate for the MBIC population. An overwhelming majority of the members at MBIC have been coping with their acquired brain injuries for upwards of 5 years, meaning that while they regularly attend doctor's appointments, their injuries are no longer in the acute phase. Add in the cognitive disabilities of the members at MBIC, and memories of past doctor's visits and what occurred during them could not be expected. This meant that the focus on healthcare had to be narrowed down to that of the Clubhouse, as it is considered a rehabilitative facility, rendering the topics of the original Megassi study irrelevant to the unique setting of the Clubhouse. The PAM-13 and REALM-R assessments were helpful in regard to baseline data and informing the direction of the program. However, it is questionable how accurate they were. The answers by some of the participants given on the PAM-13 conflict with observed behaviors and comments made by the participants seen by the researcher when out of the program setting. Several participants reported they understood their health problems and what caused them. However, when asked about the symptoms of their acquired brain injury, they were unable to answer. While 2 participants scored perfectly on the REALM-R in regard to correct pronunciation, it is questionable whether knowing how to pronounce the word means they knew the meaning of the word itself. It stands to be noted that the only participant of the program who was lawfully considered their own legal guardian, meaning they make all their own healthcare decisions, was the only one to score 0, suggesting poor health literacy. While the participants were vocal and engaging throughout the program, much of the questions and suggestions had to be coaxed out by the researcher. While participants gave input regarding the topics of the successive lessons, it was the researcher who had to give options for the participants to agree on first. It is unclear whether this was due to the low understanding of topics and what was being asked of them, or due to a lack of motivation to actively participate in the program. Due to the inability to translate the original products from the Megassi study, the modification of this program was highly reliant on the input and feedback from the participants. The program only completed 4 sessions when MBIC abruptly closed due to precautions regarding COVID-19. Due to this, the assessments administered pre-program were not administered post-program. While the goal of the assessments was not to test the efficacy of the program, it would have been beneficial to see if and how the participants' answers and scores would have changed in order to determine the usefulness of the assessments in conjunction with the Community Clubhouse Self-Advocacy program. Limited communication with the family members of the participants and potential participants were another limitation. Members of the Clubhouse generally utilize the PACE transportation system or other private transportation services, such as taxis. Due to this, there's limited contact with the family and guardians of the members, which made it difficult to receive approval for members to participate in the program. This resulted in a small sample for this program in this case. This is something to pay attention to when conducting future research because it may also impact the translation of information to settings outside of the Clubhouse, such as at home. The innate schedule of the Clubhouse model limited availability for scheduling the program. Midwest Brain Clubhouse is run on a strategically designed schedule in order to maintain a routine for members to follow. Due to this, the daily schedules are often packed with regularly scheduled activities. This made it difficult to find a time throughout the day that the participating members could all gather together. This was made even more difficult with the 5 other occupational therapy students completing either fieldworks or doctoral capstones at the site at the same time. Having several students at the same time trying to work with members created conflicts with timing and running of the program. All of these scheduling conflicts meant that some weeks the program was not able to run when they were originally intended to. As stated earlier, this feasibility study was designed to test the translation of the products of the McGassey study to a community clubhouse setting. The purpose of this was to better understand what products are needed to successfully complete a program focused on self-advocacy within a community clubhouse setting. This is important because, as described in the literature review, those with disabilities often experience health disparities that lead to a lower quality of life. While it was quickly determined that the McGassey study products required modifications in order to serve the unique population of a community clubhouse, it was also found that the overall feasibility of the community clubhouse self-advocacy program requires further modifications for the specific site of MBIC. Future programs would benefit from narrowing the focus of healthcare down to the clubhouse itself as a healthcare facility in which to increase self-advocacy skills for members. Although education is an important aspect of teaching self-advocacy, it could be more beneficial to minimize lecture time and maximize participation in hands-on activities to reach specific goals related to their health within the clubhouse setting. Personal lessons learned. First, I learned that flexibility is definitely key when trying to understand what makes a program feasible and acceptable. You have to be willing to make changes at a moment's notice to remain client-centered and to achieve the overall goal. It is also important to meet the participants where they are at with skills and knowledge in order to build off of those skills to then produce a program that is both feasible and acceptable. Thank you for taking the time to view my occupational therapy doctoral capstone.